associated tamoxifen use. And what we found is that the frequencies were similar between our data set and the control data set. And this really showed that there is no enrichment, at least in our data set, for any specific histological subtype. And this also allowed for further downstream analysis of the molecular data.
Thank you very much, Dr. Kubler. We're going to move on. Thank you.
Thanks so much. Thank you.
And our final presentation is from Romualdo Barroso de Sousa on behalf of his colleagues from the Nimbus trial, presenting Nimbus, a phase 2 trial of nivolumab plus ipilimumab for patients with hypermutated HER2-negative metastatic breast cancer.
Hello. On behalf of my co-authors, it's my great pleasure to present the results of Nimbus trial, a phase 2 study of nivolumab plus ipilimumab in metastatic hypermutated HER2-negative breast cancer. Listed here are my disclosures. At the time we designed the Nimbus trial, data was emerging that suggested that patients with high tumor mutational burden were more likely to benefit from immune checkpoint inhibitors. Now, based on data from Keynote 158, pembrolizumab received accelerated approval for the treatment of patients with metastatic solid tumors with TMB high defined as greater than or equal to 10 mutations per megabase. Notably, in this study, there was no patients with metastatic breast cancer included. While the prevalence of TMB high in metastatic breast cancer is around 10%, the real benefit of checkpoint inhibition in this population is not well established. In the phase 2 TAPER study, patients with metastatic breast cancer with TMB greater than or equal to 9 had an unconfirmed objective response rate of 21% with pembrolizumab. In the Nimbus trial, we hypothesized that patients with hypermutated breast cancer are more likely to benefit from an approach of dual checkpoint inhibition with the combination of nivolumab with low-dose ipilimumab. Nimbus was an investigator-initiated multicenter single-arm phase 2 trial. Key eligibility criteria included having metastatic HER2-negative breast cancer, having received 0 to 3 lines of prior chemotherapy in the metastatic setting, having a tumor with a TMB greater than or 9 mutations per megabase as assessed by a CLIA-approved cancer gene panel, and having measurable disease by RECIST 1.1. No prior checkpoint inhibition was allowed. Patients received a combination of nivolumab 3 milligrams per kilogram every 2 weeks, plus ipilimumab 1 milligram per kilogram every 6 weeks, until progression, unacceptable toxicity, or up to 24 months. Restage scans were performed every 6 weeks for the first 6 months, and every 9 weeks thereafter. The primary objective of the Nimbus study was to evaluate the efficacy of the nivolumab plus ipilimumab as defined by objective response rating according to RECIST 1.1 in the study population. Secondary objectives included safety and tolerability, clinical benefit rate, progression-free survival, and objective response rating in patients with tumors with TMB greater than or equal to 14. This analysis was a predefined analysis based upon some preliminary data in lung cancer suggesting that a higher cutoff would be ideal. The study was designed as a 2-stage single-arm phase 2 trial, and the first stage was designed to enroll 14 patients. If at least one patient achieved an objective response, then accrual would continue to the second stage, where an additional 16 patients would be enrolled. And if at least 4 patients achieved an objective response among the 30 patients, then the regimen would be considered worth of further study. This study was designed to have 90% power to distinguish between an objective response rate of 5 versus 25%. Patients were enrolled between May 2019 and June 2021, and all data presented today is based on a data cutoff of September 30th, 2021. Shown here are the patient characteristics. All the 30 patients who started treatment were female and had a median age of 63 years old. 21 patients, or 7% of the population, had hormone receptor positive breast cancer, and 30% had triple negative breast cancer. 8 patients had no prior lines of chemotherapy in the metastatic setting, and 22 patients had received at least one prior line. PD-L1 status was determined centrally using the 22C3 antibody. A combined positive score of 10 or greater was considered positive. There were 4 patients, or about 13%, with PD-L1 positive tumors. And the median TMB was 10.9, and 5 patients, or about 17%, had a TMB greater than or more 14. After a median follow-up of 9.7 months, 5 patients experienced a confirmed response, consistent with a response rate of 16.7%, meeting the primary endpoint of the trial. 6 patients had a stable disease at their best response, and 3 patients came off study before their first scan, 2 for clinical progression, and 1 who withdrew consent. Of note, 3 out of 5 responders had hormone receptor positive breast cancer. Shown here are the tumor and biomarker characteristics of the 5 patients who experienced an objective response. 3 patients had hormone receptor breast cancer and 2 had triple negative breast cancer. Only 1 of these patients had a PD-L1 positive tumor. 3 patients had tumor-infiltrating lymphocytes greater than or equal to 10, and only 1 patient had CD8 greater than or equal to 10. Exploratory analysis did not show a difference in response rate according to hormone receptor status, PD-L1 status using 22C3, and stromal TILs. And while numbers are small, patients with a TMB greater than or equal to 14 had a response rate of 60%, compared to just 8% in the group of patients with TMB lower than 14. Shown here is the swimmer's plot, demonstrating that the responders experienced long duration of benefit. The median time to response among responders was 1.2 months, and the median duration of response was 12.1 months. There are 2 patients who achieved a partial response who discontinued therapy due to toxicity and have had prolonged response of therapy without any further systemic treatment. These patients are noted with the red arrows, with 1 now still in response at 25 months and another in response now out of 16 months. Shown here are the Kaplan-Meier curves for progression-free survival and overall survival. Median PFS was 1.4 months and median OS was 19.3 months. Shown here are the Kaplan-Meier curves for progression-free and overall survival according to TMB with a cutoff of 14, which was a predefined secondary endpoint. Compared to patients with TMB lower than 14, patients with TMB greater than or equal to 14 had a higher median PFS of 9.5 months versus 1.4 months. Compared to patients with TMB lower than 14, patients with TMB greater than or equal to 14 also had a longer median overall survival, still not reached versus 8.8 months. Shown here is an exploratory survival analysis according to best response. Patients with PR experience a 12 months overall survival of 100%, while patients with stable disease and progressive disease achieved a 12 months overall survival, respectively, of 80% and 45%. The median number of cycles of nivolumab and ipilimumab were 1. The most common reason to discontinue treatment was disease progression, and 2 responders stopped treatment due to toxicity, one due to myocarditis and the other due to fatigue. Adverse events with the combination of nivo and low-dose ipi were similar to what has been previously seen with other tumor histology using this combination. Importantly, no grade 4 or 5 adverse events were reported. The most common immune-related adverse events was diarrhea. Importantly, 3 patients developed grade 3 immune-related adverse events. 1 patient had myocarditis and adrenal insufficiency, and 2 others had hepatitis. All patients recovered well. In summary, the combination of nivolumab and low-dose ipilimumab in Nimbus trial demonstrated an objective response rate of 16.7%, meeting the primary endpoint of the study. There were no new toxicities identified and no grade 4 or 5 adverse events were reported. This study supports the use of checkpoint inhibition for patients with HER2-negative metastatic breast cancer and high TMB, regardless of hormone receptor status, but does not answer the question if dual checkpoint is better than pembrolizumab monotherapy. While patients with a TMB greater than or equal to 14 were a minority in this study, they did achieve an objective response of 60%, and further work is needed to investigate the optimal TMB cutoff for selecting patients to receive checkpoint inhibition. Finally, work is ongoing to centrally confirm TMB in blood and tissue using the Foundation 1 CDX assay. Thank you very much for your attention.
Thank you. We have time just for a couple of quick questions. The first is if you could comment on the cutoffs that you used, 9 for the primary endpoint and 14 for the exploratory endpoint, how you came to those.
Well, at the time we were designing the Nimbus trial, there are common data, preliminary data suggesting that at least for breast cancer, 13 or 14 mutations per megabase would be a more appropriate cutoff. And in fact, just recently, the phase 2 MAP pathway in Britain was just published in Cancer Discovery, suggesting that even for agnostic indications, maybe a cutoff of 16 is much better than 10 mutations per megabase.
And there's another question regarding the response rate of 20% seen in the TAPER study, which leads to the question of whether ipilimumab really adds anything to nivo. It's speculative, but.
Sure. It's really important to be cautious about these cross-trial comparisons, but few things are important to mention about TAPER. First, TAPER did not present confirmed objective response. The second important issue is that at the time TAPER was designed and conducted, there was no approval for checkpoint inhibition in breast cancer, so the population is different. Our population is enriched for patients with hormone receptor positive, while in TAPER there was a mix and approximately 50% for each of this population. And lastly, our population is enriched for PD-L1 negative patients, while in TAPER we don't have this information.
Do you have any sense of how TMB evaluated by liquid biopsies correlates with TMB by tissue biopsies?
Well, one of the most important things about assessing TMB is the size of the genome that we are covering. It's really important to assess TMB with large panels covering at least 0.8 mutations per megabase of the genome. And if the liquid biopsy assay has enough genes, it's better, especially 300 genes, but there are some data suggesting that there is a little bit of overcalling when we are using blood biopsies. So importantly, we will validate our data using the blood and the tissue genomic assay of the foundation, and maybe we'll have a better answer for this question.
Okay. I think because of the hour, we're going to draw